So I'm so happy to welcome you to this session. Please do tweet about it. It's now gone from the screen, but our hashtag is QFB3, hashtag Quality 2019. So please share your ideas, pictures, reflections on Twitter, and you will have the opportunity during the session to share some of your learning with each other as we go through. So I'm going to let our speakers introduce themselves, but we've got representatives from lots of different perspectives on healthcare who are all going to be sharing their experience and their learning on how to get your ideas out there, how to improve the reach and the impact of your work, and how to really make change at scale. So please join me in welcoming our speakers.
Where's the clicker?
No.
Oh, no.
There we go. There we go.
Here we go, yeah.
No,
So I'll kick off. So we thought we would start the session by telling you a little bit about what matters to us personally, rather than the sort of standard introduction to our jobs and responsibilities and all the work that we lead. So Medina and I are going to be presenting together a little bit later on our work on social franchising. But just to kick us off, a few things that really matter to us. So I've got a picture of my beautiful niece there, Lara, who I'm really excited to be seeing this weekend, going down to visit my family. And there's a bit of a theme to the things that matter to me that I've presented. So the next picture is a group of my oldest school friends who all live on the west coast of Scotland, and I've had the chance to catch up with while being up in Glasgow, which has been wonderful. And then finally, some beautiful Scottish scenery, which is my absolute favourite thing to come and visit and makes me feel like I'm at home. So that's a picture of Loch Foyle, which is in the Trossachs, just north of Glasgow. Medina.
Thank you. Hi, everybody. I'm Modena Johnson from IRISi. The three things that I've chosen that matter to me, rather like Sarah, I'm a very proud auntie. So I've got my beautiful nieces, Ruby and Isabel, and their big brother, Jack, in England. Then I'm taking you on a trip to Wales, where I live and am based, and I will bore anybody who's happy to sit for longer than a couple of minutes senseless about my chickens and my bees and the garden that I have at home. And then the top picture, I'm taking you to Kenya, to Nakuru, where I have an African family. So for the last 14 years, I've been supporting a wonderful African project. And here are two of my friends, Jacqueline and Stephen, who are two of the young people that I've seen thrive and grow from toddlers up to teenagers.
Thank you. So first of all, welcome to this session this afternoon. We're really looking forward to delivering it for you. So some photos from me. First one, family. I came late to being a dad, but I'm making up for it and really enjoying it now. And you might wonder why Doctor Who's so important. Actually, my kids have been watching it since they were this tall. We tell Doctor Who stories when they go to bed. We discuss moral implications from Doctor Who episodes. So Doctor Who's very important to us. Wales, come from Wales, another Celtic nation here today. Wales is an amazing place to visit. So I'm doing that for the Wales Tourist Board. Tenby is probably one of the nicest parts in West Wales. And probably, like a lot of you here today, and certainly from what we've heard from the stage, believing my job makes a difference is really important to me, and I recognise that that's so much a key part of the forum. And I'm currently working for the Wales Life Sciences Hub, looking at how innovation and industry support healthcare. Thank you.
Thank you, Andrew. My name is Tina Lynge, and I come from Denmark, so English is not my first language. How many other here don't have English as their first language? Please raise your hands. Oh, okay. I almost could speak Danish. Oh, I won't do that. What matters to me is my family, my children, and my husband. Another thing that really, what matters to me is also do things that gives me energy. I have a summer house in Spain, and going down there and in Spain, some of you may be from Spain or been there, you know, the culture is very much mañana, mañana, which makes me come down in the lowest gear and really recharge my battery.
Professional, I gain energy from being around team that's passionate about the things they're doing, be passionate about, want to improve the things they are doing, so want to do it, make it better for patient. Then I have another passion, and that's the lowest picture, as you can see, is that I love cakes. I love eating cakes. I'd rather have a cake than lunch today, but there was lunch. But when you have a passion like that, that's an income, so you need to have some output. That's why I'm very happy that spinning is one of my favorite sports, so I spin 3 times a week. So, what we like for you to do now is, we also want you to talk about what matters to you. And so please turn to the neighbor and spend 1 minute each other to share with each other what matters to you.
Okay, good start.
Yeah, good start. It could be interesting if they have a mic. It could be asked. Okay. Is anybody want to volunteer? Just shout out not what matters to them, but what they heard matters to the one next to them. Why? Why? 5 why. Yes, another one? Good. Thank you. Thank you for sharing and with each other and with us. I will, over the next 20 minutes, take you through how we in Denmark have used communication to support the quality improvement and scale up in a community setting. I'll start by setting the scene from where the work has been taking place. The community setting, when I talk about that, that refers to all the home care, care homes and rehabilitation units that are taking care of the patient and deliver care for the patient. The size of the municipality we started in were about 45 to 100,000 inhabitants. When we started this work back in 2013 with 5 municipalities, nobody has ever before taken a patient safety the patient safety methodology used in hospital into community setting. So we were kind of innovators. We were learning our way around. We didn't know what was working, how would people take it. So we had to learn our way around. But what we knew was from the reporting system, we had an issue with patient safety problems. Patients were being harmed from pressure ulcer, medication, falls, and infection. So we had a burning platform to where we could start the work, or what we wanted to approve. And so we started a collaborative that took place over the next 3 years. In each of the municipalities, we started small. We started with one nursing home and one home care facility. And we had to learn what was working and what wasn't working. We also had to we wanted to develop a prototype. The purpose of developing this prototype was to make sure that we tested the ideas and processes and demonstrated and designed if it was working before we said we could scale it to others. So we went from 1 to 3 to 7, and finally we decided we could spread to the whole municipality. But before we could spread to a whole municipality, with the intervention and the work we did, we had to make sure that not only the processes and the results were in place, but also that we had the underlying mechanisms that were supporting the improvement work in place, so we were sure that this was sustaining over time. So, what did Denmark do differently? We learned that what we did differently was, and we learned that employees working in a municipality, in small care homes and home care, they had a different relationship and approach to their patients. So when you work in a community setting, you are walking into people's home, so you are actually the guest in the patient's home, but when the patients are at the hospitals, the patients are the guests. So we had to think to do this a little differently. We embedded communication as part of our improvement strategy. We built it into an overall driver diagram. A driver diagram, maybe a lot of you know what it is, but I assume some of you might not know. But let me shortly explain. Driver diagram is like a Google map. It's a visual roadmap on how to get from a given place in a given time. The aim is the destination. And in our case, the destination was creating... Oh, sorry. It hasn't gone. So, the aim, I'll go again. This is the driver diagram, this is the roadmap, and the aim of the destination in our case was creating a lasting platform for the improvements, improve and the safety culture, reducing harms, and spread and scale up the work. The primary drivers are the most important drivers that directly affects the achievement of the outcome. So we had improvement leadership, organization, we had capacity building, we have infrastructure, we have communication and social networking, we had patients and family, and we have the clinical intervention. As one of the outcomes we had was to reduce the numbers of harm for patients, we were going to look at how communication could influence that, so I will elaborate a little more on that. Yes. We use communication as a driver to support the quality improvement by communicating the why. Why are we doing the things we are doing? To make it meaningful for the staff that were going to do the job. This little model here you see is about how to engage and motivate the individual by using different tools like patient stories, events, showing result, displaying data, make people feel that they're part of something big. And this is where you talk to the head, the heart, and the legs. Depending on who we are talking to, the weight of how much we talk to the head, heart, and leg will be different, as we as humans respond different to different things. So, as I said before, the primary driver are some of the most important factors to directly affect the achievement of the outcome. So we took one of the primary drivers to make an independent driver diagram. So we actually thought communication is very important in driving this improvement work. So again, we can say, what are we trying to accomplish? We wanted to improve and sustain a quality improvement by using communication. The primary drivers here were creating a culture of celebration that support result and events, be transparent in improvement work and tell good stories. It's about promote and sharing knowledge and learning among teams. And then it's about to make it easy for the staff to find the newest knowledge and tools they can use in their improvement. Those drivers leads us to the secondary drivers that helps us identify the changes and the ideas that can be tested, that will help us achieve the improvement. I did have some hands out because we have created a model here. It's a very busy slide, so that's why it's not up there. We thought it was a small group, so I had 60 handout, but we'll put it in the presentation afterward. But we have a model of what tools to use in what phases of a scale up. To learn more about which factors the staff found were driving or hindering the improvement work, we did a survey among all the staffs and leaders in these 5 municipalities where we started. What we learned from the survey was that using communication strategic had a positive impact on the team's performance. It's, this one, 98% of the informers said that using communication helped creating a sense of common purpose and that it increases the improvement in involvement and the joy in work. We heard about that earlier today. Another thing, in addition to achieving diplomas for achieving 300, 500 days without pressure or medication errors, and also celebrating with cakes or whatever, mostly cakes, some celebrated with dinner. It also became a story on the newspaper, in the local newspaper or on the website. And that was something the staff really found interesting and enjoying. They love to see themselves presented in the newspapers. That gathered a motivation and engagement among the staff to continue the improvement work and for others to see what was possible to achieve by working systematic with the improvement. Not to forget what it means to the patient, not being harmed from things we know we can prevent if we work in a different way. It helped creating the will for new staff to do the things others have done. So here, 95% of the informers says that celebration has a true impact on the improvement work, as it makes them feel noticed, acknowledged. They feel that they're being seen and heard for the work they are doing. Another thing, it is not to be underestimated what it means for staff to be mentioned in the local newspapers or on the website. They have expressed that it increases their work satisfaction and their desire to continue doing the work. Of the informers, 82% say that it gives them the pride in the job they're doing and also in the workplace where they do the job, and motivates them actually to do an extra effort. And I think when staff working every day hard in people's home are saying things like that, that makes me reflect that small things can actually make a big difference for the staff. So, this is about how a patient story can have an impact on improvement. This is a story of Ida. I'll let Ida tell her story herself.
Det er siden jeg har backtracket, der husker jeg, det er en gang med at gøre boller. Det er en gammel udskrift. For jeg har ikke kunnet, fordi jeg har været syg. Jeg har ikke kunnet. Ja, der havde så ondt i ryggen og kunne ikke få luft. Så det begyndte faktisk med. Så gik det ned og så.
I'm sorry, where are the subtitles? Huh? I have to then. I don't know if they're looking at it down there or what. They're looking at it. Okay. We'll just take a brief moment.
Siden jeg har backtracket, der husker jeg, det er en gang med at gøre boller. Det er en gammel udskrift. For jeg har ikke kunnet, fordi jeg har været syg. Jeg har ikke kunnet. Ja, der havde så ondt i ryggen og kunne ikke få luft. Så det begyndte faktisk med. Så gik det ned, og så kom jeg på sygehuset. Jeg kan faktisk ikke huske, hvordan det var ledes. Min mand og søn, de får besked ud til, at jeg ikke mange dage tilbage. Sådan var det jo. Og så sagde min sviger, hvis hun...
Can you show? Close it. I could shut it off, and I did. Good. I'm so sorry because we have tested it, and there's so many good people here have put it in here. So, well, I'll tell you. This is a story about Ida. Ida, she was very sick. She went to hospital. She wasn't eating. She was almost unconscious. The hospital said she's going to die. The family said, well, if she's going to die, she's going to come home because we don't want her to die in hospital. So Ida came home from the hospital, and the home care assistant and nurses came into her home, and they have transformed her living room to like a hospital room with hospital bed, lift and everything, so she could be helped there. And slowly she actually got better, and they started giving her something to eat. She was starting eating a little. Then they could start to mobilize her so she wouldn't be in risk for pressure. Also, they started her to get out of bed. And slowly she was getting better. So using story as a driver to support improvement in communication is very meaningful and strong for staff to see what they can do differently. Actually, in this story here, when we think about what is talking to her head, to our head, is that she talks about, oh, it's the knowledge base. This is knowledge base. She has pain. She was not eating. Her kidney almost stopped, and she was almost dying. And the emotion in this film is about, she's a kind old woman. I think she was 85 or something. And the family wanted to care for her home. home care staff came to the house, took care of her, and slowly she came back to life again. So this is really talking to our emotion, what the care we do for patients can actually make them do and change. And mostly all, when we use patient stories, it can always also make us think, okay, if they can do that, maybe we can do something differently. I'm so sorry that it didn't work, but that's also a test. But let's go back to this. Now it's your time. As you see here on the screen, this is a driver diagram. We have a goal, we have the primary drivers, and then there's empty fields in the secondary drivers that you have to fill in yourself. So what I want you to think about and talk with the one next to you is, how are you going to use celebration to communicate? How are you going to use patient stories to communicate? How are you going to use the website or local newspaper to communicate? And most of all, when you think about that and talk to the one next to you, which of the primary drivers are the easiest one to start with and why? So 2 minutes. Ja, det er okay. Men det er mærkeligt, vi var over, de satte det til, og alt muligt, og det virkede. Jeg tænker, gå ved, om det er noget med, at de har været inde og lave ændringer, de andre der. Nå, men altså. Men jeg ved godt, du siger 20 minutter, men vi brugte jo ikke hele de 10 minutter først, så det er derfor, jeg lige har lidt ekstra tid jo. Hvad? Oh, yeah, I'm speaking Danish to you. I was just saying, you said 20 minutes, but we didn't use all the time at the beginning, so.
So that's 20, this is 20 minutes from the first 10 minutes. You've had 20 minutes, so you've had half an hour now.
Okay, I'm just finished. When they come back, I have 2 minutes.
Okay, that's fine. 2
Yeah.
minutes, that's fine.
Yeah.
That's fine. Yeah, that's good.
How did it go?
Really good.
Okay.
I love the head, heart, legs.
Okay, yeah.
It's really lovely. And there's so much energy in the room. It's
Good.
just calm in every room. It's really good. Everyone knows about it.
Yeah.
And it was so lovely to hear her voice in Danish.
Yeah.
It was so
And we did have it with subtitles, and it's such a good story.
And it looks like a great story. And I have tweeted that we'll share your model and slides
Yeah.
afterwards.
Yeah. Good. Yeah. Thank you. I'm concerned of the time that I have 2 more presenters that wanted to present. So, but I hopefully, and the communication driver diagram is also will also be in the handout. But the point here is like actually using communication as a driver the same way as we would do if we were building capacity or we were doing the clinical intervention. So it's a driver diagram and it's a strategy by itself. Okay. This morning we all had to learn about how to be a Scottish, right? So I thought, now it's time to learn how to be a Dane. In Denmark, we have something called hygge. It might be not as difficult to say that some of the Scottish words, but hygge. And hygge is something, it's you have to experience to know it for real. But it's linked, but you can say it's linked to the culture about celebration. We like to celebrate whenever we can. If it's having a small beer or cake or wine, we like to celebrate. And also the teams like to celebrate. So this picture is a picture of my last learning session where over 300 people were gathered for the learning seminar. And what they were celebrating was all the good results they have achieved by now, and the engagement and the energy they had to go home and continue the improvement work. So with this picture, I'll hope that, that we, when we all leave tomorrow, go home with a lot of new ideas, and maybe you can take some of these ideas I have put out here, and we'll put our hands up high and say, this has been a great conference. So thank you for your attention. Over to you, Andrew.
Thank you. Okay, so thanks, Tina. So we've heard from Tina in terms of the importance of strategically planning communications to support improvement work. We've heard about the role that patient stories play. We've heard about actually using press and media to engage our staff in order to tell their story and to share their accomplishments. And actually, this kind of all links into something that we launched at the forum last year called the QI Comms Charter. How do we look to build strategic communications into our improvement work? Because actually, what's remarkable about improvement, we are very set on having a very clear methodology to drive improvement forward. We always need to be focusing on building in a measurement plan. But actually, what's often missing is the communication strategy to underpin it. And we've learned from industry the amount of investment that goes into industry in terms of the marketing and the communications focus in order to bring about change, in order to sell a product. And in the same way improvement has learnt from other industries, perhaps this is an area that we need to be learning from too, in order to scale up that focus and in order to keep people connected. So QI Comms Charter there, 7 principles that you might find helpful as you think about your quality improvement work, and also think about how you build communications into it so that it underpins it, drives it, and actually makes it successful. So today I've got 20 minutes to talk to you about the role of social media in supporting quality improvement work. I'm delighted to be joined by my colleague Rachael Trask from Aneurin Bevan University Health Board in Wales, and we're going to take you through a bit of a case study of how we use social media around a Pressure Ulcer collaborative. So we'll tell you a little bit about that later. But let's kind of look at the picture at the moment of social media. Every time I see this image, I'm overwhelmed by it. We kind of talk about Facebook and Twitter at the forum, but somebody called Brian Solis pulled this infographic together to illustrate just how many channels there are out there, how many opportunities there are. And perhaps as us being innovators and improvers, perhaps we need to be kind of stepping out of our standard focus on social media. But what he did say is social media gave everyone a voice, which is a positive statement, but actually it means we're in a very busy space when we're talking and sharing and looking to communicate our improvement work. So needing to plan it, needing to ensure that we are taking the best opportunities is key. He also said in terms of this infographic that actually you, i.e. in terms of your work, is at the centre in social media, but actually we've got commitments to listen, to engage, to learn and to co-create in order to make social media truly effective. And there's something else that he said. Social media is about sociology and psychology more than technology. And I think that's an incredibly powerful quote when we think about how we apply social media to improvement. It picks up on the psychology of change that we've heard about this morning. That actually when we start thinking about how we use social media to support our improvement work, are we thinking about our audiences? Are we thinking about the people that we are seeking to engage and to connect with? Or are we just sending random messages out there? So a bit like what Tina was saying and a bit in terms around the QI Comms Charter, effective use of social media to support a collaborative, to support a campaign, to support large-scale change really needs an understanding of the audience and in terms of how we're going to connect with them, but also the challenge of kind of being in this space. So I'm going to hand over to Rachael, who's going to introduce you to the health board, and then we'll unpack the case study for you. Rachael.
Hi, so my name is Rachael Trask. I'm the improvement lead in a place called ABCI. We're actually in sunny South Wales, because I believe it's sunny there at the moment. And in Wales, we don't have hugs or hugger, we have cwtches. So for the Welsh people in the room, they'll know what I'm talking about. So I work in an Behrens University Health Board. It's a real privilege to work there because it's named after the founder of the NHS. And I work in a place called ABCI, which stands for an Behrens Continuous Improvement. So I'm here today, actually, I'm a bit of a fraud, really. I'm talking on behalf of my colleague, Dr. Doris Behrens, who's been leading the work on the Pressure Ulcer Collaborative. Unfortunately, she's in Austria at the moment, so I'm her proxy today. Just a little bit more about ABCI. So ABCI is quite a unique improvement hub within an Behrens University Health Board. We're quite unique in the fact that it's not just improvers like me who are in this particular area. We've got clinicians who work with us. We've got affiliate, associate directors that work with us. But what's probably quite unique about ABCI is that we've got a unit of postdoctoral mathematicians who help us to build insight for the organisation. And effectively what we do in ABCI is we work in 3 areas, all focusing on improving care for our patients. So we work to build capability. So that's where I come in. I'm responsible for building skills for quality improvement and measurement, but also leadership. And we've got quite an extensive program of modelling, building modellers within the service. We have a focus on innovation. How do we support innovation across the organisation? How do we support those ideas that staff come up with and build those into our organisation? I've heard lots of stories this morning about how people have brought their own ideas into improving care for patients in their organisations. And the third bit is in the delivery, and that's the bit we're going to be talking about today. So in delivering learning, delivering improvement, we do that through running collaboratives effectively. And one of those collaboratives that we're running is the Pressure Ulcer Collaborative, which aims to reduce pressure ulcers for our patients.
Thank you, Rachael. We'll come back to that in a moment. I spent a year working with ABCI, and one of the key things was looking at their communication strategy, how they communicated to their key stakeholders, which were their staff and the frontline staff. And actually, why this is important in terms of a social media presentation, it's about working out what you're going to say, how you're going to say it, and then consistently delivering it. So what you'll see through the statement on the screen was a key statement for how the organisation was going to engage with staff. So it was going to become a friend of the front line. It was going to build relationships of support and encouragement that educate, support, champion and celebrate progress. Now that might sound a given to you, but other organisations might position themselves as the experts, as the leaders in the field, as the ones that you go to for help and solutions. But actually, ABCI wanted to be much more collaborative, it wanted to be much more relational, so a friend of the front line became its mantra. And that actually what it does help you do in terms of social media, in terms of your writing, in terms of engagement, in terms of presentations, you have something there, you can decide which way you're going to play it. So sometimes on social media somebody would say, let's tweet about the fact that it's David's birthday in the team. And actually that's not what the social media focus was about. We're friends of the front line. It's not about the team. So that was really key for us in terms of how we shaped our social media. And then we chose to look at social media in three ways. that we would contribute, so that we would encourage members of the team and those that we worked with to contribute to healthcare improvement discussions. And I suggest that's a lot of what goes on at the forum over these days. It's that contributing to the discussions and the conversations. The second one was to create. So to actively create content, whether that was blogs, video, photos, infographics, images, because you will know that on social media, content is king. On a personal level, when you flick on your Facebook account, you'll know that it's actually the things that have got a photo or an image or a story that will have you click in the button to find out more. So for us in ABCI, it was key to actually do that. And then the third area was to create. Again, I think that goes on at the forum a lot in terms of identifying those ideas. But actually, the one that we focused on was really that second one, in terms of as we built that sense of support for the front line, that we would actually go out, connect, meet, and tell their story. So that kind of links up our kind of overall position, how we use social media, but it did also shape how we communicated and how we tweeted. Now, I recognize, going back to my earlier chart, there is far more one social media channel. We chose to use Twitter as the key one, but I'd actually suggest that a lot of these kind of rules and guidelines that we applied would work for most channels. So again, it's not about us, the improvement team, it's about them, the front line, the staff on the front line. So actually getting that focus right. So we would challenge tweets or content going out that kind of deviated from that. We really wanted to catch staff doing something right. Sounds a bit of a strange statement, but often staff are under pressure and challenged. But we actually wanted to say, how do we on our social media catch them doing something well, the great work that they're leading on improvement? And through it, we wanted to tell stories of success, achievements, and noble failure. Because we were discovering that if you keep talking about success, which is absolutely critical, as we know, to improvement work, it can actually leave those who are not seeing those successes slightly left out of it. So how do we kind of bring it into our social media content, that focus on failure? The key thing was that we wanted to create content that people were prepared to share. That's where social media works particularly well, in terms of that, creating that material that people will comment on, discuss, and engage. And a key one that we identified quite early on is that sometimes when you start or begin a social media account, you almost look for like global domination. You've got your account and you want to get the whole world on board. What we actually identified in ABCI was that the community we wanted to build were actually the frontline staff living in the area, working on the wards. And when we kind of identified that as a group, it became much easier to work out what content we were going to create and how we took that forward. And then a key one was we wanted to teach frontline staff how to use social media for improvement. And I'll come back to that in a moment. But Rachel's just going to give us a minute on the Pressure Ulcer Collaborative to give us context.
And I was one of the people he taught how to use Twitter, because I was completely useless before. So the Pressure Ulcer Collaborative aimed to reduce pressure ulcers by 50%. It has bypassed, he's completely bashed that aim and has achieved this in a sustained way for 10 of 12 wards that have been involved. Social media, so we've used social media quite extensively as part of the collaborative, and I think this has been really useful in sharing successes, actually sharing some of those failures and supporting staff who have gone sort of 200-300 days without a pressure ulcer and then having a pressure ulcer. It's actually it's heartbreaking for those staff. And our communications around that has been definitely focused on driving out fear, destigmatizing failure, learning from failure, seeking it out and learning from it. So social media has been brilliant for the Pressure Ulcer Collaborative. I really have a feeling that it's made a difference. because it's starting to build that sense of community for all the staff that are involved. We have very avid Twitter feeds as we go through every learning session, and the tweets sort of last for days afterwards. And what I think is particularly useful is one of the comments from the presentation previously was those people without a voice, those quiet people getting on with it, doing their improvement, have got a voice, and you're starting to see these people bubble up and become really key members of the improvement community.
Thank you, Rachel. So again, very keen to start creating in terms of supporting that Fresh Wells Collaborative, getting those voices from the front line, from senior staff, from the nursing director, and again, helping shape those messages so that as they went out, there was that sense of engagement around it. And linking to this, as I said earlier, how do we create content that gets shared? So again, you might be thinking around this in terms of your work, but how do you write news stories that go on your internet that you can share on social media? And we found that with a lot of the news stories that we wrote, we actually went out onto the wards, took photos of the staff, asked them why improvement was making such a difference. We wrote the stories up, and the staff just got really energized again because they saw themselves in that picture, in that place, and it kind of added to that sense of energy that Tina mentioned. You know, the adage still works well. A picture's worth 1,000 words. I think it's worth a lot more on social media. You'll have been, but again, thinking about the photos, what are the images that you need to capture? So we got a bit creative around Mr. Potato Head, as I'm sure many of you will, but we also helped staff to write the story around the tweets, because at one point we were quite concerned that all the staff on the health board seemed to be tweeting about doing Mr. Potato Head, and you kind of left thinking, who's looking after the organisation? So we actually worked with them to tell the story around it. Infographics. We can create infographics much more simply these days, but actually, you know, pulling out those key numbers that engage, that connect, and that people can see their story in it. And one of the key things that we did quite a lot of was we took loads of photos of staff. We took loads of photos of staff and asked them how the work was going. We tweeted them, we shared them on Facebook, and again, that really led to good engagement. Somebody told me kind of in the beginning of social media, they said, Andrew, people don't follow corporate accounts, people follow people. And I think in the main, that's true. But actually the real value of a corporate account, like we created within ABCI, was the opportunity to create content, and then this is a staff nurse to comment, so it's going out to her community, it connects, it praises. This was the director of ABCI celebrating staff based on content that we put out. And again, we touched on the failure, but actually we tweeted about the failure and allowed the program manager to comment on it. So that's some of the, in a sense, how we've kind of used social media and really importantly, the content. But the other thing that I mentioned was how we train staff to use it. So this is Michael. He was textbook for use of social media. He was tweeting his staff. He was tweeting progress. He then set up a personalised a team Facebook account to kind of model this. And he really got it in this comment. And I've got a short video coming up that I'll play. But you'll see it on the other side, Mr. Potato Head. We actually worked with our improvement team to help them take photographs that communicated the improvement that they were doing. So I'm just going to leave this presentation with Michael as he explains how we use social media and the impact that it made to his work.
I joined Twitter several years ago, and I think like a lot of people started putting random tweets out, but then didn't really get the point of it. And stopped. It was only piece I began once I got involved with ABCI, because I understood it's about building a community. It's about building lines of communication between different areas, and it's about promoting the good work that we're doing, because obviously the community that we serve, they're able to see our tweets, and it's good for them to feel like we're taking an active role within different areas of healthcare that they'd be interested in. So that started, and now there's other members with my team who are on Twitter. We're making great connections with other wards within not just the Gwent, but across the health board. And in fact, we're learning from people. I've learned things from people who are in New Zealand with regards to things like sepsis as well, and pressure ulcers. So it's a great way to share best practice.
Good, thank you for listening. I'm going to hand over to Sarah and Medina now.
Hi everyone. So you've just heard two great presentations about different ways of using communication to support scale. We're going to take a slightly different approach and talk about a specific mechanism or way that we can support improvement interventions to scale. So I'm Sarah Henderson, and this is my colleague Modena Johnson. I work for the Health Foundation, which is an independent UK health charity working to improve health and healthcare in the UK. We do this by building evidence of what works, of testing, of enabling and supporting teams to test that in real-world settings, and then to share that learning with the broader system. Medina is the chief exec of one of the teams that we've funded, and she'll tell you a little bit more about her role and her work later on. But social franchising. So we've done lots of work at the Health Foundation around trying to understand how to support the scale and spread of interventions and approaches, and why that's hard. And some of you will have copies of this report on your chairs, which is the culmination of some research that we did last year. For those that don't, you can pick it up at our stand. But it sets out some of the challenges that we observed that our teams had with scaling and replicating their improvement work. And when we heard about social franchising from an organisation called Spring Impact, who've used this approach primarily in the international development sector, we suddenly thought maybe this could help with some of our problems, or support some of our teams to scale their interventions more effectively. And the reasons that it really sort of appealed to us as worth exploring was the greater level of support that it offered to implementers and adopters for the work that we were doing. We know that it's hard work doing the initial innovation, but actually not enough attention is paid to the people who then go on and have to adopt and take on the intervention in new contexts. And social franchising offers support to do that. We also noticed with a lot of the teams that we support through grant funding that when our funding ends, they fall off a cliff edge, with teams disintegrating, project managers leaving, fixed term posts ending, and it can be hard to keep momentum up. So an approach to having sustainable financial support for teams leading this work felt really important, and social franchising offered a potential way for that to happen. Finally, this kind of age-old question of how much you have to ensure fidelity to an intervention to make sure it works and to build on the evidence, but also paying attention to local adaptation and new contexts, and how much work needs to be done locally to make an intervention work in a new place. And again, social franchising offered some helpful principles to support people through that process. So I'm conscious that many of you may not know what social franchising is. We didn't know before we heard about it. So based on the fact that I knew nothing at the start, I'm going to sort of start at the beginning and give some bit of headlines of how it actually works. And many of you will be aware of commercial franchisees like McDonald's or Subway or The Body Shop, for example, who are excellent at replicating their product, replicating the quality of what they do so that you get the same experience wherever you go. But most of those businesses are owned by individuals or groups of businesses are owned by individuals. And what Spring Impact had done was thought about whether that could be used, those approaches, those principles that underpin that effective replication, could those be translated to be used for social good and for social value? So that's where social franchising comes in. And this slide just sets out some of the key components of social franchising that make it different to other models of spread or dissemination. So the most important bit is that arrow across the top, which goes both ways. So there's a legally binding agreement between the franchisor or the originator and the franchisees, who are the adopters who are taking up and implementing their intervention. And as part of that agreement, there's responsibilities on both sides. So the franchisor gives a brand, a product, a clearly described intervention, as well as support around training and implementation support, and a set of quality standards as well, so that you can understand if something's being implemented well. On the other side, franchisees pay a fee for that, so they're actually purchasing the intervention as such. They are responsible for complying with the quality standards, and they provide data to the franchisor so that they can monitor the success of the intervention and as the network as a whole. So we thought there was lots of interesting stuff in there, but we wanted to understand actually whether there was any evidence behind whether this works or not. And the answer to that is some sort of, but it's not very good quality. And there's not very much in high-income settings. So most of the work has been done in international development sector, as I mentioned. And these are just some screenshots of a couple of sort of large-scale evaluations that have happened, which, to be honest, had patchy results. And it was very clear that social franchising itself is not sort of magic bullet, but the implementation and how it's actually done is very important as well. On top of the concerns around the evidence, we also weren't really sure it would work in an NHS context. Would NHS organisations be willing to enter into franchise agreements? Would that legally binding agreement and that exchange of money, would that be a problem? We were concerned about the commercial sounding language of franchising and whether that would be off-putting in a healthcare system as well. And would we be able to find teams who'd actually be interested in developing these franchises and building what could be seen as businesses and to really commit to that as a mechanism for scale? So those were our practical concerns, but we also had the concern at the bottom of that slide there around whether it would actually deliver better and more effective scaling of outcomes and interventions than current models. So we had lots of questions. But we thought there was enough in it to try and test it out and to invest some money in understanding if it could work. So we designed a funding program which was deliberately explorative in nature. We had these 3 goals which I've set out here. So the first one to test with a small number of projects whether it was possible to do this and whether it helped innovators scale their interventions. We invested heavily in an evaluation to understand whether it's managed to deliver the outcomes that we hoped and what the experience of teams building franchises was. And finally, we wanted to learn about this issue of contextual factors and adaptations and whether franchising could support and help us learn more about that. And we commissioned an evaluation partner, Collis, to help us with that. We were also tried to be very honest with our partners and with our teams that this might not work, and there might be a time that our teams turned around to us and said, this is not an approach that's helpful for us and we don't want to do it anymore. And equally, as a funder, we might have the same perspective. So we tried to be very honest across partners around some of those concerns at the beginning. But we found our 4 teams, and Medina is obviously going to tell us a bit more about IRISi in particular in a minute. But just to sort of flash these up, you can see how different they are, working in different parts of healthcare with different types of interventions, from your more traditional improvement approaches to some more technical interventions. But what these projects had in common is an evidence base behind their original intervention. So we knew that it worked in their original setting. They also had some experience of scale, and that was important to us, that there was a maturity around the teams as well. So I'm going to hand over to Medina now, who's going to tell you a bit more about IRISi's experience in particular.
Thanks, Sarah. Okay. Hi, everyone. I'm Modena Johnson, and I'm the Chief Executive of IRISi, Iris Interventions. We're a relatively new, young social enterprise. We established as an organisation, a not-for-profit organisation, just 2 years ago. And we were born from research, academic research, based in 2 centres, which I'll come on to in a moment. We exist to promote and improve the healthcare response to gender-based violence. Our mission and vision are up there, which we've been supported to create through our work with the Health Foundation and Spring Impact. And our whole being as well is partnership, collaborative approach. So co-production of whatever we do between the specialist third sector around gender violence and our partners in healthcare. So we know that not one organisation or sector is responsible for support around gender violence, and we were passionate that we had our health partners in from the start to work with us around that. Our flagship programme as an organisation is IRIS, which stands for Identification and Referral to Improve Safety. As I said, we developed from a randomised controlled trial, which was run from 2007 to 2009, again with support from our wonderful partners, the Health Foundation. We had a very positive trial. We showed very good outcomes by doing what we were doing, which was a general practice-based training and referral program. So although a complex intervention in research and academic terms, in terms of what it delivered practically, it's a very simple intervention. So there are at least two local people in any site, a clinical lead and a specialist support worker based in the third sector around violence and abuse, who are the local team who train practices around recognising patients with issues of violence and abuse, knowing how to ask them, respond, refer and record, and a very simple referral pathway so that the clinician asks the question, Pandora's box is opened, but they don't need to deal with what comes out because that's referred straight on to the specialist worker, the advocate educator. We know that it increases referrals and identifications, it improves well-being, safety, quality of life, and it's also cost saving, so kind of winner all round. We, in the 10 years since the randomised control trial, have grown with sort of a sapling oak tree, if you like, from our acorn start. We have some commissioned sites, we have a number of clinical leads, and a number of advocate educators implementing our programme in those sites. As at last year, about this point last year, we were working in around about 1/10 of the general practices in England and Wales, and we'd had over 10,000 direct referrals into our commissioned sites from patients affected by violence and abuse and seeking support. So as you can see from that previous slide, we had some success. We were really keen, as Sarah said, that we demonstrated these good outcomes. We didn't want that all to fall off the cliff edge once the research was finished, but we had some significant challenges. We were being approached by potential partners who wanted us to work with them to support them to replicate what we'd been doing. But we were a tiny team of 2 of us working part-time, trying to support all these sites and put systems in place and grow. We knew that sites we were supporting to replicate weren't necessarily even 60–70% sticking truly to our model, which caused us concern in terms of reputational risk, and in terms of people saying, well, we've bought your project, but actually it's not working in the way that you told us it would. So, what's going on here? We also found, interestingly, that people who liked what we were doing tended to take our name, our brand, and use it as shorthand for anything around domestic violence and abuse and gender-based violence in health, which on the one hand was great, but on the other hand was also dangerous to our brand and our reputation. And we were also trying to grow within a very difficult commissioning environment of austerity, all of us trying to do more with less money and fewer resources. Oops. So when we were approached by the Health Foundation to work through this, we were really interested because we were already kind of part way on this journey. We'd never heard of social franchising, even though it was kind of what we were doing already. But we were very, very aware that we lacked robust processes. So we weren't being systematic in the way that we recruited sites. We had no contractual arrangements at all. So those 30-odd commissioned sites all trusted us on a nod, a handshake, and an email. They were giving us their money, and we were going to deliver what we said. So we'd never had any contracts in place, which left us quite vulnerable, and our commissioning partners quite vulnerable. We had no quality assurance processes in place. So we trained people, we gave them our package, we offered ad hoc support if they wanted to ring us, but we had no robust quality assurance processes in place. And as this all grew very organically, we didn't know what we didn't know. So we didn't know that we should be having manuals. We didn't know how to operationalize and systemize what we were doing. And we also, although we were charging people to buy our model and charging them an annual license fee, we didn't have a robust financial model to actually tell us, if you get this many new sites on board, you're likely to be able to recruit this many new team members, which means you can grow and sustain and grow and sustain. So in terms of the work that we've done so far with the Health Foundation and Spring Impact, I just thought it would be useful to share some reflections of how the process has gone for us. It's been absolutely invaluable to be able to stop, have shared team time, facilitated team time, to reflect, discuss and plan. We'd never done that before. We were on a wheel of, oh, somebody wants to buy the project, yes, let's go and support them to deliver it. We never said no to anybody. We never stopped and thought, are these actually partners that we want to work with? Are they IRIS ready, or do we need to help them get IRIS ready before we support them to commission what we're doing? We had no process. So the third point up there shows you the process that we've gone through, the 6-step process, as part of our social franchising journey. And we're now systemizing what we do and about to enter our testing or validation phase. So actually the core model, the evidence-based model that we have from the randomized controlled trial, that won't actually change, but what will change is how we operationalize it. And finally, the real excellent support that we've had means that we're now partway through developing operational manuals. The last couple of days while I've been here, my project manager Lucy's sending me chapters to sign off and agree, so all of that is absolutely underway at the moment. We have a financial model. We know what we need in order to sustain next year and the following year. And we're very excited that we have 4 sites who want to work with us and who want to test out this model of support. So we're looking very much forward to our next steps.
Thanks, Medina. So just to finish off with some sort of overall programme insights so far, as Medina said, we haven't yet operationalised, we haven't yet finalised the project, so we don't know yet whether social franchising works, but we've had some really interesting learnings so far. The teams are just at the point of piloting their new models of scaling, having gone through the systemisation and the development of their manuals over the last year and their financial model. But these sort of insights have come out so far. So first of all, that actually it's really hard and requires a degree of sort of technical skills that actually most teams in improvement won't have around legal agreements, financial models, and agreeing data sharing agreements, for example. So that's not straightforward. We found that teams were generally able to identify what their intervention was, partly because of the evidence base they had behind it before, but had underestimated how long it would actually take to describe that well and to actually codify what their intervention was. It became clear that you needed a relatively mature team in place, so you need to have some infrastructure, whether that's project management or business development, some kind of role is able to do the business side of the business side of the project. And we found that our first hunch was correct. The language of social franchising is challenging in an NHS context, but teams found imaginative and creative ways around that by using terms that were more familiar to commissioners and were easier to understand. So instead of a franchising agreement, we have teams having service level agreements or memorandums of understanding or whatever works in their local context but delivers the same outcome. The quality control systems have been challenging as well, so finding metrics that are easy enough to collect the data for, but actually give assurance about the quality of the implementation and of the outcomes that are being achieved. this second last point, I don't think we'd anticipated, but maybe we should have done. Because these teams were at a level of maturity where they'd already spread to some extent, we've now got teams running parallel systems where they have different arrangements and agreements with some sites that they've worked with for a long time, and then others that they've brought on through the franchising model, and how do they move from one to the other and support both of those ways of working at the same time. And then finally, social franchising we thought would be a really helpful way to get to financial sustainability, and I think we still really hope that's the case. But it's become increasingly clear that there is a relatively long runway to that sort of magic moment of financial sustainability, and that it takes a while for teams to come on board, and it takes a while for the franchise fees to build to a sufficient amount that you've got core infrastructure. So some kind of grant funding or support in other ways is probably necessary while teams are building their franchises and getting their model in order. So I'm going to pause now just to give you a minute or so to have a chat with your neighbour. I'm conscious I've just given you a lot of information, maybe just to reflect on it, what makes sense, if anything, does it resonate with you, and is this an approach that you could see working in your context? So just have a minute of conversation with your neighbour about that. Yeah, that's it. I'm just going to finish it.
It's harsh, but they're a very kind audience. They're very nice and settled. So
Yes, I know, that's fine. The last bit is just to say thank you.
yeah, we're good on time.
No, well done. I could see you thinking about.
Gloss over, gloss over.
It goes so quickly, doesn't it? No, it does.
Yeah. I enjoyed listening to Andrew.
Yeah. No, it was good, wasn't it? It was much more engaging than the quick run through. Made a lot more sense.
Second's a long time when you're standing up here, isn't it?
It's funny standing at that table as well, and I was like, should I be watching Medina or should I look at? Great, I'm just going to...
Yeah.
Okay, thanks very much, everyone. We're about to go into break, so obviously feel free to carry on these conversations into the break. But just to finish off the session, a big thank you for coming and listening to us. As Tina said, this was a much, much bigger audience than any of us anticipated, so thank you. And we'll be around at the front if you've got any questions or would like to find out any more. Thank you.